I'm Rick Stern. I have two roles. I'm the Chief Executive of the NHS Alliance. So the NHS Alliance used to have primary care trusts in its membership. And now all of you who are in CCGs will know that you're now part of NHS Clinical Commissioners, and we have a relationship with CCGs. But we're primarily there to champion general practice and other providers in primary care out of hospital. And as part of that, we produced a report, Breaking Boundaries, back in March, which tried to lay out a manifesto for primary care. So a positive view at a time when general practice was being given a pretty hard time and felt pretty hard done by for many reasons. And since then, the Secretary of State has made a number of remarks which have not made that any easier. But the report looks at all the difficult divisions in the system and tries to suggest how a system in the future might work more effectively, from the relationship that's at the heart of all of it between a GP or a nurse or another practitioner with us as patients, becomes as equal as it can be in making choices that are right for us, through to the boundaries with hospital and how we can pull down the walls of hospitals, not because we don't think they're actually, we don't necessarily think they're always great places, but we do think that there are lots of brilliant people in hospitals who could be probably better deployed elsewhere within the system in the future. And I guess that also picks up on resources, that over the last 8 years, primary care has got a decreasing part of the cake at the time that it's meant to be doing more and more. The resources, one way or another, have ended up in hospital. So how can we actually, instead of trying to shift resources, which very rarely seems to work, how can we ensure that the people who are there work more effectively across these artificial boundaries that we create around beds and organisations and sometimes around professions? Enough of that. If you're interested in joining us at our conference in a discussion around how to create a better primary care system across systems as a whole, please join us. If you're interested in membership, email me, and we'd love you to be part of it. But I think the main reason I'm here today is as a director of the Primary Care Foundation. We've been up and running for about 7 years now. We're small, but we've done a series of reports for the department. I'm going to talk about some of that work and what it might mean. What I should have said at the beginning of all this, of course, is that given that we now have 30 minutes, is this will be more engaging if you interrupt. Otherwise, I'll just carry on talking, and you may regret that. So, as and when I say something that you think is particularly ridiculous or provocative or interesting or any of those things, then just interrupt in whatever way that you think is useful. So, let's please do this as a conversation rather than just as me talking. Okay, so these are some of the sorts of initiatives that we worked on. We did a report which subliminally got flashed in front of you by Russell Emeny, or not quite that fast in a slide, but in 2009, it was the first piece of work which looked at the role of general practice in the urgent and emergency care system. And I think before that, it was generally not really thought of. General practice was not thought of as being as central to how things were done. And after that, everyone seems to at least acknowledge that 100 million same-day appointments happen in general practice. I'm not suggesting for a second those are all urgent. Very few of them are genuinely urgent, but they're activity that seems same day that may need an urgent response. So I'm going to tell you a bit about that work, how it's led on to doing other work with general practices. We've now worked with nearly 1,000 practices across the country to analyse their data, put it into a web-based tool, produce a report that says where you're at as a practice, and then engage in a conversation about what that means and how you might do things differently. This doesn't have a magic bullet solution. It isn't that sort of actually all you need to do is triage all phone calls and life will be easy, or introduce 111 and the system will suddenly become easy and simple too. Generally, I think magic solutions are to be entirely distrusted. What it does do is look at a whole series of ways that people might improve the way they work and make life simpler, particularly for the people who work in general practice, and then for patients and for the system as a whole.
Can I ask you a question?
Yeah.
When people talk about primary care, they often mean general practice.
They do. I'm not meaning that.
The whole primary care.
Primary care in its broadest sense. So certainly, if we're looking at the beginning of the system, it's the wider community and you know.
Supermarkets, buying your paracetamol.
Absolutely, yeah. Pharmacy sees a lot more people than general practice does. Not always having, you know, sometimes that's a commercial relationship, but a lot of opportunity for many others to be interacting with people and making their life easier and addressing their health needs. So, yeah. In Breaking Boundaries, one of the key things we put in the report was how we look at in an asset-based way at the wider community and look at the potential to use the support and capacity that's available. We all know that, you know, that if we costed in carers to the system, it would bankrupt the system if we ever actually paid people the amount of support they put in. So yeah, absolutely, I acknowledge it's much broader.
Did you look at how these primary care actually communicate with each other? Because the patient might go to the pharmacy, might go to out of hours, might go to their own GP, but they actually haven't seen the whole picture of that patient. And they take several weeks to get to the bottom of the problem, and by which means they may have been limited by their needs, because the actual systems do not talk to each other. So I don't know whether it's an area that is being looked at.
Sure, and I'll come on and talk about that more, but you're right. It's I think one of the difficulties of the system that was already acknowledged earlier this morning is that it's fairly complicated, increasingly fragmented. New forms of access were introduced between general practice and A&E, but that offered more choice but didn't simplify things. And I think that's a real challenge. I think the key point that I will be trying to make in a circuitous way this morning is actually that primary care has a key role in all this. And if general practice, let alone wider primary care, if general practice makes things simpler and easier for us as patients to get into the system and have our needs identified, that has a profound effect on the system as a whole. But it's often more attractive to focus on a few A&E departments than 9,000 practices across the country, which are all systems which in themselves are frequently fairly fragmented. So in most practices, direct conversations between the partners and the nurses about how they work and how they operate and what that means for the care they provide are unusual. So yeah, it's not stuff that we're used to doing. I'll move on slightly. If I've got time, I'm going to try and address some of these areas. What happens in primary care and A&E, general practice, out of hours, and then how it all fits together. We'll see where we get to. I wanted particularly to highlight this. Here's a real version. You can download it from the website. Chris Ham kindly tweeted that it was a good thing to look at if people want to try and understand how the whole system fits together. What it tried to do was to offer a commissioning guide for those of you dealing with urgent care in clinical commissioning groups. And it tried to look at different parts of the system and say how they connect and how they link. So there's some simple messages in there about what seems to work and what doesn't, some of the myths around the system, but crucially, the influential role of general practice in all this and how we ought to focus on that part of it. The kind of key messages, I won't go through them here. In fact, I'll just focus on the one that's sort of staring out. No disrespect meant to Devon that's picked on there, but these are not unusual signage in NHS institutions that, you know, here's a choice of 4 different services, all of which sound similar. I mean, you could all guess exactly what they are and what they are, but, you know, pretty confusing as a patient walking in and trying to make some sense of it. So we don't often make it easy, and we really should make it a bit simpler than that. I'll probably pick up on some of these themes as we go through. Quickly to touch on primary care and A&E, we did a report for the department in 2010, just before the election, that said we were asked to really look at, firstly, at this whole question of actually isn't a lot of what A&E departments do really primary care, and what's the best kind of model if you're going to do this? Our answer to the big question on sort of is it all primary care was, well, it's probably a lot less than people think. We thought it was 10 to 30%, but more than that, it's probably the wrong question. It was kind of a so what question. It's actually, if people turn up at A&E, we'd probably do better to respond to their needs more effectively. And not surprisingly, when we looked at the different models, we were less than thrilled by ones that seemed to be set up in an adversarial fashion that we as a PCT, and I say this as a former PCT chief executive many years ago, that we as a PCT need to prevent the hospital pulling in patients to make money. And just in the end, that doesn't get you very far. Doesn't seem a very effective way for a system to work together. So our view was that in terms of governance and patient quality and safety and just good value for the system, that when you pull together primary care clinicians and secondary care clinicians and get them to work in a team, that tends to work rather more effectively. There were, I think, a number of misconceptions around how all of this might work. We've seen this slide already. So one of them is that there's sort of endless rising A&E demand on A&E departments. Well, actually, there isn't. The big rise is in walk-in centres and urgent care centres, and that looks very big, 5-6 million, a lot of extra attendances. If you actually think that, rather think of it in terms of the 15 million people in A&E, the 14-15 million people in A&E, think of it in terms of the 100 million people who are trying to get same-day care in general practice. Actually, this is 5 or 6% of that, and I think probably particularly in London, it's another route in, it's another form of access. The judgment for urgent care systems now is it a good use of resource? Is this the best thing you could do with it? Or would you rather invest it somewhere else? Does it confuse people, or does it give you a good route in? Do you know, I'm not even going to deal with some of those others for now. We can come back to them if it's useful. I'd like to come on to this whole question of urgent care in general practice and some of the work we've done. Let's say we've developed a web-based tool to take a week of information from a practice. They have to load it up, and we can then analyse it. About 1,000 practices across the country have now done that. And it really looks at, can they get through? So what's the telephone system like? A lot of people still don't have enough people answering the phone at peak times, or there isn't the appointments available on a Monday morning when lots of people want an appointment. Fairly simple things about sort of demand or when people want to use it. A whole piece about will people be spotted who have really urgent needs. So we developed something we call a reception quiz, which isn't to get reception staff to be clinicians. That's absolutely not the intention, but it is that if you're on reception and someone calls in and says, I got a funny feeling in my chest and there's something going on in my arm and I had a big curry last night and I'm not kind of sure what it is, they have to respond, and they have to respond either, they have to pass it on somewhere from call 999 through to book it in a week on Tuesday. And what we do is we get receptionists across the team to say how they would respond to about 14 different scenarios. And the issue for us is the variation. So as always, it's that there's and I think practice is often quite shocked that some people in the team have a very different response. So the opportunity then is to get them all together with members of the clinical team and say, well, how would we respond in our practice? In our practice, we think you should always interrupt the doctor, because that's probably the best thing. That can happen really fast. In some practices, actually interrupting the doctor is a dangerous thing to do as a receptionist. Not many, but that clearly would make... Yeah.
I just wanted to say, I was recently doing some work with practice in Crawley, and
they're
in Crawley,
yep.
And they actually have senior decision making taking telephone calls.
Yes.
And that has actually cut their access requirements by about 30%.
Yep.
So, and I just wanted to point out, in the same way that senior clinical decision making is the best route in elsewhere, there is something about, I'm always concerned, because in social services we trained up people to assess child protection that really couldn't do it because they hadn't had the level of training. And I just wonder how much a receptionist, even if they do a quiz, actually can say to you, well, I know I've been treating you for a scan and this is whatever. I know that what I need you to do is just come in and pick up a referral to the hospital, and I'll do that. You don't have to sit in a GP surgery for 55 minutes then, waiting for him to see somebody that's much more urgent.
Yeah.
So I think it's
whatever the system is, they shouldn't be sitting around waiting a long time. It should be dealt with rapidly. I absolutely get the principle of you want a senior decision maker doing things quickly. I worry about everything being triaged by GPs, because potentially, it works brilliantly in some practice. Some people have made it work very well, and that's great. But actually, quite a lot of people don't want to be dealt with on the phone, or you have GPs who are not particularly good on the phone. So what we tend to recommend, I think the phone It's not new technology, but it should be used a lot more. But the phone, sorry, slightly losing my track. Yeah, the phone is, lost my train of thought.
It gets rid of those that just want a blood test referral or
Yeah.
something like that. So it's not necessarily a substitute for
It, it's not. But what we tend to suggest is it's best to offer the patient a choice. One of the things that we've discovered increasingly is that if nothing else, if you give patients what they want, let alone what they need, but give them what they want, it's more efficient. I'm not saying it's necessarily always the best thing to do, but it is more efficient. If you give patients what they don't want, they will come back again, or they'll go elsewhere in the system. So what we've suggested in many practices is giving people a choice early on in the day between, actually, would you like to talk to the doctor on the phone, or do you want to come down and see them? Because for many people whose first language isn't English, who come from a different cultural background where, unless you lay hands on people, it really doesn't count, plus many other situations, it's going to be pointless to deal with it on the phone. It will come back again. So, yeah, I'd take a slightly different approach, but the principle of first decision maker, getting contact quickly, is a good one, if that makes sense. Sorry, it's a slightly long-winded approach with a break in the middle. Because we now have 16 minutes, I'm gonna flick over some of this. You can look at it. So this is the kind of information we tend to collect. Lots of stuff about what consultations there are, some general stuff about philosophy of the practice. So, for example, one of the things we ask is, are some of the GPs more popular than others? And it's an interesting question, not just because most people smile when you say that, but it's generally, we all like to be liked, but some people like to be liked more than others. And generally, a popular doctor is someone who calls people back more often than others and who makes their patients very happy and annoys the hell out of their colleagues who have to get through work quicker to make up for them. Possibly. There are other scenarios around that. But what it highlights in many cases is discussion that should be happening across the practice and frequently doesn't about different consultation styles. Is it okay? Is it not? But the broader point here is that there is quite a lot of activity that happens in practices that isn't useful. So people coming back because they don't see the doctor that they want to see or who knows them, or people who have been called back more often than NICE guidelines suggest, is not useful activity. So we came to a really interesting sort of observation after spending time in lots of practices. Was I presumed at the beginning that if you go into a practice with a higher than expected consultation rate, so there's more appointments with doctors and nurses than in a comparable practice, that patients would like that. Well, what we also do is pull in the GP patient survey for the practice. And actually, if anything, there's a relationship between more appointments and unhappier patients. And I think that's because actually there's more activity, but it's not necessarily useful activity, and it's people being triaged and redirected or coming back for other things. So there is something about trying to get people seen quickly in the right way, with the right person, in the way that suits them. And that will be different for different people. So we had the sort of the slide about young males in A&E. Well, how young males want to receive care is probably quite different to someone with a long-term condition who's over 70, and the practice ought to be able to adapt what it has for all of those different groups and many others. So actually, trying to sort these things out makes life easier. In fact, our starting point with practices is your life should be a lot easier than it really is. That too many people work too hard, put in too many extras, and it could be simpler than this. So there's a case for more resources. There is also a case for using existing resources better, which in turn will have quite an impact on the system as a whole. Let me move on to this bit here about finding those few urgent cases. Yeah?
I just want to make a point with numbers, and I fully take on board everything you're saying, and we do the doctor first system, so
Okay.
it's actually,
Yep.
it slightly is in line with what you're saying, slightly not, but
Yep.
I know you're not making a call for resources, but a number for England.
I'm happy to make a call for resources too.
Resources
Yeah.
are quite an important issue. A basic number
Sure.
for England is that many APMS contracts are stipulated on providing 130 appointments weekly per 1,000 patients. Older contracts are stipulated on 72 appointments per 1,000 patients weekly. This would only be
The national average is about 115 or 120, but yeah.
But these numbers, which many
Yeah.
contracts are stipulated on, are only accurate if you have a patient who attends the practice between 3.5 and 4.5 times per year, which is below the national average of 5 years ago. So I did a basic costing of the system, which showed that for an average 10,000 patient practice, the 72 appointments per 1,000 patients, which is widely accepted across East London, minus some areas with APMS contracts, would require 4.1 whole-time equivalent GPs extra just to provide the national average of 5 years ago. So I think that the issue with resources is massively important because it tells you no matter what system, you will always be under-resourced. So we've looked at telephone mapping systems where the number of receptionists that you would need in a practice to answer calls at peak time, you would need resources of 2.5 practices to provide that resource for the demand. So I kind of get your point, but it still works within a system where resources so grossly unmatched to demand that the problem remains.
I don't disagree around resources, and we use a figure of not 3.5 to 4.5, but 5.5 as the average.
Yeah.
And but we could bore everyone else with numbers that probably wouldn't be helpful. But the point still remains that with the existing resources, people can do it better, and some practices do it a lot better than others. So I think it's both. It's not one or the other. It's both.
Just a reminder about the resources.
Yeah, no, absolutely. I just think just saying we're underpaid, we don't have enough money, we haven't got enough resources isn't good enough in the current context of saving 20, 30, 50, 100 billion pounds or whatever we're looking for at the moment. Okay, so to just come on to, this is particularly looking at home visits in general practice. Home visits are not in themselves, well, they tend to have a greater acuity than someone who walks through the door, but a very few of them will need some rapid intervention. Most of them, actually, there's the potential to avoid doing home visits and actually deal with them in another way. The current traditional approach in general practice, and still prevalent in most practices, is that someone calls 8:30, 9 o'clock, you might assess them 11:30, 12, 12:30, lunchtime, you all get together and hand out who'll do what home visit. You visit them by, 1:30, 2 o'clock. If they need an urgent intervention, then you have to try and get the ambulance service to take them in. You might get them there by 5:30, and lo and behold, because we don't have 24/7 hospitals, most people have gone home, and they're really likely to end up as a hospital admission. The point was made earlier today, I think, by Russell. If you get people into the system really late, they're bound to be an admission. However, it is possible to do it differently. And what we suggested in our report 4 years ago, and we've worked with people on it, is not there should be a national target, but locally people should think how they might do this differently. And what we suggest is not that you do home visits immediately, but that you screen them with a call. That you call them and check and find out. And it does two things. The first thing you do is identify the quiet individuals who are actually really quite sick and need something happening with them, and they're the important ones. What it also allows you to do is to check out those who really don't need a home visit at all, and you could deal with in a different way. And lots of people have said we can cut our home visits in half by quickly screening them in 30, 60 seconds. But the bit I'm more interested in is being able to spot those few who need a rapid intervention. So if within a few minutes you pick those few, you can then, if necessary, get them to hospital much quicker. And the chances of being able to do something, well, there's two things. Firstly, the system can cope much better at 10:45 or 11, but also the whole medicine of acute illness means that the quicker you get hold of them and the quicker you deal with them, the better their mortality and the more likely you are to have an effective response. For people who like the evidence, this is about mortality increasing substantially the longer the delay that takes place. And actually, if you look at this, the delay of about 9 hours and mortality increasing dramatically is similar to if you leave it from 9 in the morning till 5:30 at night. Okay. We've got about 8 minutes. We're sort of swimming in time. All I wanted to say about out-of-hours services is I agree with, they frequently get a hard time. Many of them are actually a lot better than they were in 2004. We have a national benchmark, which most former PCTs bought into. You can see how most services across the country compare and what they look like with pretty colours and maps and lines and all sorts of things if you want to go on our website. What we're looking to do, different ways of mapping different things, what we are looking to do is try and extend it into an urgent care benchmark. So trying to look at the whole system, which is clearly more profound and more of interest to many of you who are looking at systems as a whole. Difficult to do, but working with the College of Emergency Medicine and colleagues up at Warwick who've done, so people like Matthew Cook who've done a lot of work on this in the past to try and make sense of it, how we build in 111 and the impact of that. So that's what we're looking to do. I mean, clearly you have other tools as well. I actually think the dashboard, the urgent care dashboard, is a really useful tool and a great way of looking at individual patients. What we're looking at is something as a system-wide and the impact. I was going to have a brief rant on 111, but maybe that's not entirely helpful. I do think, and it clearly has done better in London than it has done in other areas. I've had to been closer to services up in the northwest and the West Midlands, which survived hours before collapsing, following claims of what people could do within contracts which were entirely unsubstantiated. It was depressing. The point is, and I think it's the point that was made earlier, is actually 111 is probably brilliant if you put it on top of a good, well-functioning, integrated system. Unfortunately, not many of us have a truly well-functioning, integrated urgent care system. We might be getting there, but putting it on top of a less functional one might make things more difficult rather than easier. So I think that's my concern. I think the other is that the local ownership was nowhere near as good as it should have been. Trying to introduce it at the same time as clinical commissioning groups going live was ambitious. And it's maybe an example of a big political ambition to fix the system in one go, which looked attractive, but is far more complicated when you get into the detail. I'm sure many of you know a lot more about sort of how it's worked out within your local patch. So, what are the key messages that I'm trying to share in this? I think the first is that general practice is the bedrock of the system. If you get it right in general practice, if access is really good and smart, we're able to spot people quickly and get them through the system quickly, it will have a profound effect on the system as a whole. The trouble is, it's much harder to work with 9,000 or in case of London, 1,500 or whatever the number of practices is. Much harder to make small little changes and little wins in lots of systems than it is to focus on a few, but it's the only way to really profoundly re-engineer the system as a whole. I think there's still too much on offer. I don't think, I thought there was a lot that was attractive about the additional investment in, 5, 6, 7 years ago around urgent care centres and polyclinics in London. But I think people will need to make a fresh judgment as they develop their local plans and as you develop them presumably within your urgent care networks about, is that the best use of resource or are there other ways of doing it? Being seen promptly is always a good thing. As patients, we love it. And clinically, it's a good thing too. So the more effective we make, the more efficient we make our systems, the better, the more people like it, and probably the better it will be for our healthcare too. I do say it, there's a strong case for more resources. So I do agree. It's up there in black and white. But variation, there is loads of variation, and we need to acknowledge that and do something about it. Great fan of clinical commissioning, great opportunity, but I think those of you who are at the forefront of it need to be really brave and need to start saying no to things and start deciding exactly how you want things to be for your local community, how possible that is within an increasingly, within a framework that's developing and people are finding their roles in terms of area teams and regions and NHS England and those of you, and I'm sure there are a number of you here from NHS England who are sort of developing your roles and working out quite how it all fits together. But if there is not space for people, those clinical leaders who are the best people to develop and shape services, then we'll have missed the whole point of these reforms. And finally, there is no big idea. It's lots of small little things, so good luck.